All right. Hello, everyone. Welcome to Study Medicine Europe's first 2023 symposium. Today, we will be learning about approaching falls on the ward. We're very excited all of you can be with us today. So, just a quick introduction for those of you who are attending one of our symposiums for the first time. These periodic symposiums are dedicated to presenting relevant information and trainings related to medical, dental, and veterinary fields. These free webinars are open to all SME students as one of the many services we provide throughout your academic career. They're great opportunities for you to learn and ask questions from professionals in your field of study. We also will provide you with a certificate of attendance after each symposium. So you can include as additional training courses as part of your resume at the end of your studies. So to get that certificate, we'll provide you with a QR code at the end of the symposium. And from that, you can also complete a feedback form for us and then receive your certificate of participation. All right, so here's the agenda for today's symposium. Hopefully by now, most people have joined. So we will be turning it over in a minute to Dr. Joshua Soggi for his presentation. When he is done with his presentation, we'll have some time for a quick Q&A with him. For the Q&A, to protect people's individual data and avoid having your names appear on the screen because this is recorded, we're going to have the Q&A function open. So throughout the presentation, please feel free to type your questions. I encourage you to put them in there anonymously. It is an option you can select. And if you do put your name in there, when we get to the Q&A, Dr. Soggi won't read off your name. He'll just read off the question. Again, just to make sure we're protecting people's personal data because this is a recorded webinar. So as you think of questions, feel free to put them in the Q&A function and we'll get to them during the Q&A time. All right. If you are ready, Dr. Soggi, turn it over to you.
Okay, so thank you very much for the introduction. So today I'm going to be doing a talk on how to approach falls on the ward. And I know that I think predominantly people tuning into this webinar will be medical students. So when you finally graduate as doctors and start working as junior doctors, this is going to be something which you will definitely come across during your time spent on the wards, if not on the wards, during your out of hours work. So hopefully the things that I'm going to discuss today about how to approach falls on the ward, you can incorporate into your workings as a junior doctor in the future. So how common are falls in the hospital? And the answer to this question is very common. So inpatient falls are actually the most frequently reported safety incident, which is a big thing and which reiterates the fact that you most likely will come across a fall whilst working as a junior doctor. So more than 250,000 were recorded annually in both England and Wales, which is, again, is a significant amount. And the thing about falls is they do have a relatively high percentage which result in injury. So as you can see on the screen, about 30 to 50% usually result in injury. And with being junior doctors, you are the people who are going to be reviewing these patients for the first time, most likely. So that's why it's important to have a thorough, systematic approach when approaching these falls, so that if someone does have an injury, you're able to identify it, you're able to identify any problems as a result of the fall itself, and you can manage the patient safely. And also prevent further falls as well in the future for the patient. Again, around 5% of the falls lead to a fracture, which is, again, a high number if you think about it in respect to how many patients have a fall per year. And one of the big things is it costs the NHS a lot of money. And as you can see on the screen, 2.3 billion per year, which is a lot. And that's mainly because when patients have falls, this leads to prolonged hospital admissions for the reasons seen on the screen. They result in an injury, which maybe the patient was medically fit, but now they've had a fall. So now they stay in hospital because, you know, they've developed a fracture or they've developed muscular injury, which means that they're no longer able to walk how they used to be. So now they need ongoing physiotherapy a bit before they go home. And prolonged hospital admissions is directly led to like increase hospital infections, which can increase mortality. So it costs the NHS quite a lot of money. And like I said, it increased mortality. So each year around 684,000 people die from falls globally, which is a lot. And I included this screenshot, which is taken from the government website, which I think is just a nice visual representation of falls itself. So I think one thing to note about falls is your majority going to come across a lot of cases where the patients are quite old and elderly. So I've seen on the screen 30% of people aged 65 and over will fall at least once a year. And for those aged over 80, it's around 50%. And whether you're on call or whether you're in the emergency department clocking patients, falls are the #1 reason why people are taken to the emergency department in the first place. And anyone who comes in with a fall who's had a fall before in the past, they're always at risk of having another fall in the future. And I think one of the reasons why it's particularly prevalent in elderly people is because in the relatively younger patients, we have good reaction times. If we do fall, we put our hands out, we prevent ourselves from getting injured. But in the elderly patients, it's a lot different. They have a lot of comorbidities. They're very frail. They're very fragile. They have muscular atrophy. They have osteoarthritic changes in their joints. The reaction times are a lot slower. And so, this again puts them at increased injury of falls as well as an increased risk of fall in the first place. And again, it reiterates the cost of the NHS. So what are some of the risk factors for falls? So I've made a list, which you can see on screen there. I think these are the things to think about, especially when you go and see patients on the wards, or whether you're in the ED department, just to think about some of the risk factors which could potentially promote a fall in the patient that you're seeing. So #1, do they have poor balance? How do they usually walk? Are they walking with an aid? Do they walk with a walking stick when they're at home? Do they mobilize with a walking Zimmer frame when they're at home? Do they use any walking aid at all? And if so, do they now need one if they're coming in with falls or had falls before in the past? Visual impairment. So if they're impaired visually, obviously this is going to promote a fall. So anyone with, diabetic retinopathy or macular degeneration or cataracts, glaucoma, anything like this, or whether they wear glasses, again, this can promote a fall. If they have an underlying cognitive impairment, it can also put them at fall as well. So the patients themselves might, be fluctuating in confusion, and maybe they're trying to get out of bed and go to the toilet when in actual fact they're not safe to go on their own. Environmental factors is also a big one. So by this, it could be things like the patients wearing very loose clothing, which promotes the patient from falling over. So they get up in the middle of the night, they've got their dressing gown on, but they stumble over their dressing gown and have a fall on the way to the toilet, for example. Advanced age, so greater than 65, for reasons which sort of already touched on before in the previous slide. And whether they've had a history of falls before in the past. Like I said, if someone's had a fall in the past before, it puts them at an increased risk of having a fall again in the future. Whether a patient is agitated or confused, and I think this is an important one, only because when you're working on call and you are a junior doctor working out of hours, you always get called by the nurses to say, this patient's more confused than usual or more agitated than usual. And typically, there obviously is an underlying reason as to why that is, but usually this is the reasons why they've had a fall in the first place. So that's something to consider. Medical history. So if they have any underlying past medical history, which could mean that they're a bit more unsteady on the feet, for example, with someone with Parkinson's disease, maybe a bit more unsteady on the feet, which is going to have them at an increased risk of a fall. And again, dehydration is another one, which is important to consider, because dehydration can lead to, hypotension, and low blood pressure can lead to dizziness and lightheadedness, which can promote a fall in the first place. So these are just some of the risk factors just to bear into consideration when thinking about falls. So I thought it would be nice to just sort of categorize things which can cause a fall, and list a few reasons for each category, just so that it's a bit more simplistic for you. Because I know when working as a doctor, sometimes you can get over bombarded with information, and sometimes it's quite hard to remember everything all at once. So I thought this was just a nice simplistic way to distribute the causes of a fall that you might see when you're on call working as a doctor or on the wards, and it'll be helpful for you. So number one, I've put cardiovascular. So bradycardia, so a slow heart rate, can essentially lead to a fall. Any valvular pathology, so anything like aortic stenosis, for example, which prevents the blood distribution going around the body, can lead to a fall. Postural hypertension can lead to fall, and any arrhythmia can also lead to fall as well. So let's say, for example, atrial fibrillation that a patient was in with a fast ventricular response, and they're having heart palpitations and they had a bit of shortness of breath, and that's what caused them to have a fall in the first place. Number two was neurological. So a stroke or a TIA can also contribute to a fall. And so if you do go and see a patient and for whatever reason you suspect maybe a stroke or a TIA, you can ask the patient whether they had any sort of limb weakness at the time. Was there any slurred speech? Was there any like facial drooping that you can see on examination? What's the power? What's the tone in the limbs? Is the sensation intact? How are they on their feet? Is there any instability? So all these sorts of things. Parkinson's disease, again, as discussed before, for the past medical history, these patients sort of have a shuffling gait and are quite unsafe on their feet in the first place. Peripheral neuropathy is a good one to think about, because you do see this in a considerable amount of patients, especially elderly who are diabetics. They may have some underlying peripheral neuropathy secondary to the diabetes. Paroxysmal myopathy and seizures as well. So with seizures, when you're going to go and take a collateral history from the nurses or HCAs, or a history from the patient themselves when they've had a fall, as we'll discuss further on in the presentation, whether they had any tongue biting at the time when they had the fall, or any incontinence at the time. Were they rigid? Were they shaking? Were their limbs shaking? So all of these things that are important to ask the patient when they've had the fall, to decipher what we need to do in the workup for the patient. And the third category was environmental. I spoke about a bit of the environmental causes in the risk factors, but I've listed a few here. So wet surfaces, these are all not necessarily medically related, but sort of outside. So any wet surface that a patient might slip on, if there's poor lighting in the room, so it's very dark and they can't really see where everything is, so they have a fall. Loose clothing, which is the one I mentioned beforehand. Inappropriate footwear, which is quite a frequent one actually that's seen. Especially, it doesn't necessarily have to be shoes, but socks as well. Sometimes I've seen a couple of patients where they've had falls because, number one, they haven't put their slippers on before they started mobilizing, or their socks weren't on the right way. Also, the bed rails being too high, which can be a cause of a problem for a patient, because especially if they're quite short and the bed's too high and they try to get out of bed, then and if they don't necessarily use the call bell to ask one of the nurses to come and help them, they try and get to the edge of the bed and then sort of jump off the bed themselves, and that can lead to a fall. And inappropriate walking aids as well, which I sort of touched on. But let's say someone usually walks with walking Zimmer frame, but then they get out of bed and think that they can do it on their own without the aid, and then they have a subsequent fall. But the environmental one is duplicated on this side. But the last one that I want you to remember is medication. So benzodiazepines. So I don't expect you to remember exactly all the medications, because I think that's virtually impossible. I think it's nice to know that some categories of medications. Now, there is a good list on the BGS website, which is the British Geriatric Society guidelines, and it will tell you some of the medications which can promote falls. But benzodiazepines can promote falls due to the side effects, antidepressants, anti-epileptic medications, diuretics can, because it causes hypertension, which can potentially lead to a fall. ACE inhibitors, which again, the same, alpha receptor blockers and beta blockers. So when assessing a patient, when they have a fall, we will always review the medications, which we'll discuss further, but it's just important to note some of the main categories which you may come across in patients who have had a fall, which you can then suggest in your management plan going forward. So I wanted to talk about the main lesson from this webinar is essentially how to cope with a patient having a fall when you're working out of hours, or whether you're on the ward. Because I know my first time when I had to assess a patient, and it wasn't very clear, like I hadn't really had any teaching on how to do it. So I did have to speak to my senior colleagues and speak to my other colleagues who I was working with alongside at the time, just to make sure that I was doing everything the correct way. But it would have been nice to have a webinar like this so I could know how to do a somewhat systematic approach when assessing the patient. So let's say you're working out of hours and then you get bleeped by the nurse, and you call the nurse back and she says, "Hi, doctor, I've got a patient on the ward who's just had a fall. I need you to review them." And you're like this chap here with question marks going on. You're thinking, I do not know what I'm going to do when I go and see this patient. So I don't know. We'll leave the Q&A till the end. So I think the first advice I would give you is to utilize a phone call when you ring the nurse and she says, "I want you to come and assess this patient that had a fall." So I would say, don't just like hang up the phone and think, okay, I need to go and assess this patient's had a fall. I don't know what to do. Try and utilize your conversation to get as much information as you can from the nurse before you go and assess the patient. And not only is this going to be helpful for you in terms of you thinking in your mind about what may have potentially contributed to the fall itself, but you can also ask the nurse to do things within that time of you taking the phone call to you eventually getting to the ward, so that you're not sort of wasting time and doing it when you get there yourself. Because when you're on call, you are going to be quite busy. And I always say that when you're working as a junior doctor, it's very important to have good time management, to prioritize your tasks and to ask for help whenever you need it. And here we're trying to perform good time management, essentially. So in short, when you call the nurse back after she's bleeped you, and she says that she wants you to come and review a patient who's had a fall, you can, in short, ask over the phone what happened. So if the nurse knows what happened, she will tell you. And usually they're quite good in telling you whether it was a witness fall or unwitnessed fall. And by that, I mean a witness fall in terms of someone was there who observed the fall themselves, or whether no one was there at the time and to see the patient fall. And so the patient fell when they were alone at the time. Also, what's important to ask over the phone is, did the patient hit their head? And this is important, as we'll discuss later on, in terms of the investigations needed. Now, there is nice criteria to say whether a patient will need a CT head or not. And for example, if someone was on anticoagulation, according to the NICE guidelines, they would need a CT head performed within, I think, 8 hours of when they had the fall. So again, this is getting you thinking about what you're going to be putting in your plan when you go and see the patient and do your assessment. And just ask the nurse, how are they at the moment? You know, are they in pain? Are they more confused than usual? So just getting the nurse's opinion on how the patients are can tell you a lot, because again, nurses are typically people who know the patients a lot better than you do because they spend a lot more time with the patients. So if there's anything wrong or anything that the nurses are worried about, then that is something obviously that you need to be concerned about. Whilst you're on the phone as well, you can kindly ask the nurse to get a full set of observations. Now, like I said, time management. You may be with a sick patient when you get this bleep, and so you're not going to be able to get there straight away. But if you could kindly ask the nurse to take some observations at the time, so that when you get to the ward, maybe in like 10 or 15 minutes time, at least the observations are done and they're there and you can see them. Also, I would strongly recommend when you get a call from the nurse and she says that they've had a fall, ask for an ECG. ECG is a very simple, quick investigation, which will tell you a lot about the patient and it contribute a lot to your workup plan going forward. And last but not least, capillary blood glucose level, which again is a very simplistic investigation to get. It's just literally a pinprick on the patient's finger, and it will tell you whether they have a low blood glucose level, and if so, maybe this was contributing to the fall at the time. So you're already ticking off a few things that you would have otherwise done if you went to go see the patient straight away. Okay, and like I said, you're going to be busy when you're on call, so you have to prioritize your tasks and have good time management. So make sure you utilize the phone call. So once you've had the phone call, then you do get to the ward. You want to establish exactly what happened when the patient had the fall. So there's two ways. You can either ask the patient themselves if they are compos mentis and they are GCS 15 out of 15 and they don't have any underlying cognitive impairment, then you can of course get the history from the patient. And I think it's easy to separate into three separate categories again. So what happened before the fall, what happened during the fall, and what happened after the fall. So before the fall, you want to know exactly what happened. So what was the patient doing at the time? Were they trying to get out of bed? Were they walking to the toilet? You want to establish what the patient was doing at the time. And then you also want to establish what sort of symptoms was the patient feeling at the time. So as you can see, did the patient have any dizziness at the time? Did they lose consciousness at the time? Were they feeling generally weak at the time? If so, was there any weakness within the arms or the legs? Did they have any chest pain at the time? Palpitations, shortness of breath? So all of these things are very important in establishing the potential cause for the fall itself. For example, if the patient was complaining of a bit of chest pain and palpitations and felt as though the heart was racing before the fall, and you get to the ward and the nurse has kindly done the ECG for you, and you look at the ECG and they're in fast atrial fibrillation, then you could say, okay, maybe the fall was secondary to the atrial fibrillation. And you look at a previous ECG and they were in sinus rhythm. So it's a new onset of AF, and what the patient is describing to you could be that this was contributed to the fall itself. What you also want to know is what happened during the fall. So when they fell, what hit the floor first? Did they hit their head when they fell? Again, that's important to know whether you're going to get a CT head or not. Where did they land on the body? Are they in any pain at the moment? Were they pale or flushed at the time? And if they don't know, and if the fall was a witness fall, you can ask a collateral from one of the nurses who were there at the time when the patient fell, or one of the healthcare assistants, etc., one of the members on the ward. Did it look as though the patient had a seizure? So again, going back to whether there's any tongue biting, whether there was any urinary incontinence or fecal incontinence at the time, whether there's any limb jerking at the time, and if the patient isn't able to tell you anything which happened during the fall, then they potentially had a loss of consciousness. So that's one thing to note. And then once you've established what happened during the fall, then you want to go and ask what happened after the fall. So once they've fallen, how did they get themselves up off the floor? Did they get themselves up themselves, or did the nursing staff come and get them up? How long were they on the floor for? So if they were on the floor for a relatively long time, then you want to think about whether there's any sort of muscular injury which could lead to rhabdomyolysis, for example, in which case you might want to do bloods including creatine kinase and check the renal function. Was there any weakness anywhere after the fall? So have they noticed like a right-sided weakness or weakness in their right arm? Was there any speech impairment after the fall? Are they now having difficulty expressing their speech? Is there any confusion after the fall itself? And that's particularly important to know in if they did hit their head. Now, if they hit their head during the fall and now they're confused, again, that's a criteria for a CT head. Did they have any vomiting after they've fallen? And do they just generally have any pain anywhere? So these are important things to know when going to see the patient for the first time and getting a history of why they've fallen. Yeah, and I think this is a very important bit to include. Always ask the patient, why do you think you fell? Because if the patient has capacity and they're able to give you a history on what happened during the fall, most of the times they can tell you why they fell. They may have said, oh yeah, I know I was supposed to be walking my frame, but I just wanted to get the book from the bedside table. So I thought I'd just reach over and then I lost my balance and I fell. And so in which case, it's not really anything which has brought on the fall itself, other than the patient mistakenly doing something which he shouldn't have otherwise done. And again, ask, is this your first time falling? Because if it is their first time falling, then we want to establish why the patient fell. And once we've established why, we can then prevent further falls in the future. But if it's the patient's, if it's not the patient's first time falling, then we need to establish, why are they falling in the first place? Again, to prevent future falls. And if they have fallen before in the past, again, it puts them at increased risk of having falls in the future. So we really need to be thorough in our assessment. So when we go and see the patient and we do take a history, it's important that we can also utilize the notes as well. So when you're on call, always look through the patient's notes and get a background of the patient themselves as to why they've come into hospital in the first place. Were they admitted for a chest infection? Were they admitted for a fall that they had at home? And that's why they were brought to the emergency department. And the treatment that they've had since they've been in hospital. Also, it's important to look through the past medical history, anything which could be contributing to the fall itself that they've had. So again, if they're diabetic, that's why we ask for a capillary blood glucose level over the phone when the nurse bleeps for the first time. But even if they're not a diabetic patient, sometimes it's still good to get a capillary blood glucose level, because again, like I said, it's very simplistic investigation to get. It's very quick and it can tell you a lot. And it's only a small pinprick, so it's not a big deal. Do they have any underlying visual impairment? Parkinson's disease, peripheral neuropathy, if they're known to have recurrent urinary tract infections, if they have a history of alcohol liver disease, in which case, they might be unsteady on the feet or in alcohol withdrawal at the moment, for example. Have they had any previous fractures before in the past? And arthritis, have they had previous, like a total knee replacement due to osteoarthritis? So it's important to go through the patient's notes in detail to understand why they've been in hospital for the first place, and a bit of background information on the patient themselves in terms of the past medical history. So once we've done that, we then want to examine the patient. So we've already established what's happened during the fall, before the fall, during the fall, and after the fall. We've already established why the patients come to hospital in the first place and their journey throughout hospital. But now we want to do our examination. So when you go to examine the patient, you can start off with a few questions, very simple questions. So you can do like an AMT4, where it just tests the cognition of the patient to see whether they're confused or not. So by the AMT4, it's 4 simple questions where you ask, do you know where you are at the moment? Say, yes, I'm in hospital. Do you know your age? Yes, 82 years old. Do you know your date of birth? They can tell you the date of birth. And do you know what year it is at the moment? So if they're able to answer all questions, absolutely fine, then, you know, they don't have any underlying cognitive impairment really, and the GCS is 15. Now, if they at all seem confused, you can do what's known as a delirium assessment. And one of the validated tools that I would recommend is known as the 4AT, which I will come on to the slide after this. But it's essentially, you can do a 4AT by asking 4 different questions, category of questions, and that will tell you whether, based on the score, the patient is at risk of delirium or has a potential cognitive impairment. So once we established, you know, how the patient generally is, whether alert orientated or not, we can then proceed with the AT examination. So I'm assuming that most of you are familiar with the AT examination. It's sort of like the bread and butter of the junior doctor's examination when they're on call. So A would be for airways. So if you're talking to the patient and the patient's talking back and there's no issues whatsoever, you can assume that the airways, they're maintaining their own airway and it's patent. B will be breathing. So you want to examine the chest. You want to see if the patient's in any respiratory distress, for example. You also want to auscultate the chest to see what the chest sounds like. Maybe the patient has new inspiratory crackles to the right and left bases on the chest, which otherwise weren't there on the previous examination, which you could see through the notes. So is this potentially a new chest infection? C, you want to listen to the heart. Is there any audible murmurs that you can hear? If so, what grade is the murmur itself? Like I said before in the past, under the cardiology categories of one of the causes which could promote falls is valvular abnormalities. So something like aortic stenosis, which is quite severe, could cause you know, syncope in patients, especially on exertion, which can promote falls. So that's one thing to know. And whilst you're doing the AT examination, because you already utilized that phone call conversation with the nurse, they've most likely already done the observations for you and have told you the observations. So you already know the patient's respiratory rate for breathing. You already know the patient's blood pressure for circulation, the heart rate, the saturation. So, you know, all of that, again, is prioritizing things and making things happen quicker than they would have. Like I said, you're going to be scarce of time when you're on call, so you need to make sure these things are done in an organized manner as well. So you've done the circulation bit, and then you go into D. So record the GCS of the patient. Also in D, this is where we include the capillary blood glucose level that the nurse has already kindly took for you, because you told over the phone. So you know the capillary blood glucose level at the time of your examination already. And then lastly, E, exposure. So this is where you want to expose the patient and you want to examine the patient from head to toe. Now, you don't want to make the mistake of, when you go and see the patient and then you discuss about the history of the fall, the before, the during, the after, and the patient says, oh, I fell and I landed on my right arm, and that was it really. You don't want to, on examination, just examine the right arm, because that's what the patient fell on. You want to do a thorough head-to-toe examination, irrespective of what the patient fell on themselves. So I would recommend starting from the head and then going down toward the feet, so you don't miss out anything. So you can start with any, just from the bedside really. Is there any sort of bruising or laceration to the head itself? Did the patient have a head injury? Is there any cervical tenderness on palpation? Is there any spinal tenderness on palpation? Does the patient have any neck pain? Do they have good range of motion of the neck? Yeah, like I said, is there any visible bruising or swelling? And then you want to test the range of motion of the arms, particularly if the patient said, I fell and landed on my right arm. So you want to check the range of motion of the right arm, check that there's good abduction, check that there's got good adduction. see if the patient is able to raise their arm well, and see if there's any pain on palpation of the elbow joint or the shoulder joint. In which case, if there is, and there could be a fracture, or you're going to get an X-ray of the shoulder, an X-ray of the elbow. So these are the things that you need to think about in your assessment. And then moving down, palpate over the hips and the femurs. Check for tenderness again and pain. Is there any signs of potential fracture here that I need to be worried about, so that I need to get an X-ray of the hips? Looking at the patient from the bedside, is their leg externally rotated? Is there reduced range of motion? Is the power reduced? Again, thinking about whether you want to investigate any underlying injury via imaging. Test the power and the tone of the upper and lower limbs, and the sensation and the reflexes, are they intact? If the patient had some sort of limb weakness and that's why they fell, and now they have weakness in the right side compared to the left side, and the power in the left leg is 5 out of 5, but now the power in the right leg is 2 out of 5, and that's not normal for the patient, then have they had an underlying stroke, in which case you might want to get a CT head done. And the GCS we've already commented about, and the capillary blood glucose. So this is the 4AT examination for delirium, which I spoke about earlier. So if the patient is more confused than normal, we can use the delirium assessment tool, and that's what's known as the 4AT, which is the table on the left side. So it's split into 4 categories. So alertness. So they only score 4 for being clearly abnormal. So that if they're not alert and they're very drowsy and they're not talking back, then this is obviously clearly abnormal. So they score 4 points for that. The AMT4, which is the questions that I went through, they get scored based on this. So whether they make no mistakes, 1 mistake or 2. 3 is attention. So what you do is you ask the patient to say the last month of the year, which would be December, and then you ask the patient to go backwards in months, and they get scored on how many they get right or get wrong. And then 4 is acute change or fluctuating course. Now, this is important to know, because in order to answer this question, you need to know the baseline of the patient. So you need to know whether this patient is GCS 15 before they came into hospital and throughout the hospital until the fall. And usually you can get this through the notes or asking the nursing staff themselves. And if the nursing staff say, yes, doctor, he seems a bit more confused than normal, he's not usually like this, then you can say that that's an acute change, and that's a 4. And then anything 4 and above is possible delirium. And then I put an arrow, because if they score anything 4 above and it's possible delirium, then there is a nice mnemonic which is called pinch me, which is some of the causes for delirium. So I've mentioned this here because if someone is more confused than usual, again, going back to the risk factors, which we spoke about at the start of the presentation, if someone is more confused than normal, then they're at increased risk of having a fall. And like I said, most of the time when you're on call, you'll see quite a lot of confused patients who are now had a fall as a result of their confusion. And in these cases, when they are delirious, the underlying cause is reversible if we treat it. So some of the causes of delirium and getting patients in a confused state of mind is pain. So if patients are in a considerable amount of pain, that can lead to confusion. Infection can lead to confusion. Nutrition, so lack of nutrition, can lead to confusion. Constipation. Also alongside this one is urinary retention as well. Hydration, so lack of hydration. Medications, which we've already spoke about. Patients who are on a lot of medications can put them at increased risk of developing delirium. And if there's something which a patient has been newly commenced on and now they're starting to be a bit more confused than usual, then it could be as a result of the medication itself. And last but not least is the environment. And by that, I mean a change of environment, particularly in the elderly people. and even people with cognitive impairment, they get used to things, and they sort of know their routine, and this is what sort of keeps them centered. And when you change that, then they get acutely confused. For example, if a patient, an elderly patient or a patient with cognitive impairment, is changed between multiple different wards during their admission, this can lead to a delirium and lead to confusion of the patient. So plan. So based off of everything, so we've gone to go see the patient. We've established what happened during the fall. We've gone through the patient's notes and got a bit of a background of the patient's journey. We've done our examination of the patient. And now we want to do a plan. We want to put a plan in place for the patient. And what I would encourage in every plan to include is, number one, a lying and standing blood pressure. And that is important because particularly in the elderly patients, sometimes they do have a postural hypertension. So what happens is when they're lying and then they suddenly stand up, they get a drop in their systolic blood pressure. And this is what leads to like the dizziness and the lightheadedness feeling, which then promotes a fall. So one way to, see if that is true or not is to do a lying and standing blood pressure. So always, and again, it's very, very simple to do, takes next to nothing in terms of amount of time. So it's very important. So definitely do a lying and standing blood pressure in your workup for the patient. Number two is an ECG. Like I've already discussed, ECG is, again, a very, very simple, non-invasive investigation to do, and it will tell you a lot about the patient. And with ECGs, I've seen a few patients where, they've had a fall and everything else was completely fine. But then when I asked for an ECG, there was signs of sort of ischemic heart disease, and they had an end stemming essentially. So it's very important to not forget about an ECG. I would say, definitely do an ECG, and definitely do a lying standing blood pressure. If you're going to remember anything about falls assessment, just make sure at least you include those two in your investigations. And then thirdly, a comprehensive medication review as well. So always look at the medications, because if, for example, they have a lying and standing blood pressure deficit and the blood pressure is trending on the low side, and they're on, 3 or 2 antihypertensive medications, we can potentially stop one of them. We can potentially reduce the dose of them, so we can prevent them trending their blood pressure on the low side, which is potentially going to prevent the falls in the future. Is there any medications that they're being on, where the side effects are dizziness and lightheadedness and drowsiness, which can contribute to falls? So always have a comprehensive medication review as well. And in that would be knowing whether the patient is on anticoagulation or not. Because if the patient is, and they've fallen over and they've hit their head, you need to withhold the anticoagulation, which is very important, because you obviously don't want to forget about that, and then the patient hit their head when they had a fall, is a bit more confused than normal. You forget to withhold the anticoagulation and they get the dose, which is not an ideal situation. So that's why it's always important to have a comprehensive medication review. And so the arrow is going towards the things that you sort of find in your investigation. Now, if the patient, for example, was complaining of urinary frequency and pain when passing urine, which is why they got up in the first place to go to the toilet, and they're a bit more confused than usual, urine dipstick might be a good investigation. Where there's any concerns of any infection, in which case you might want to do some bloods for the patient. Whether due to the fall the patient has sustained injury, in which you're querying whether there is an underlying fracture, in which case you can get X-ray imaging done. If the patient's hit their head, then you want to get CT head done based on the NICE criteria. Is the patient having an arrhythmia, which you found on an ECG, or whether they have, a cardiac murmur, which you heard on auscultation of the heart, in which case, do they need an echo if they're not already had one? And if the patient didn't necessarily hit their head, but they have an underlying cognitive impairment, and you're not really sure where they hit the head, but on examination, there is maybe a bit of redness on the head or the forehead or something to suggest that maybe they did hit the head, then and they're not on anticoagulation, you can think about doing your observations, and you can do that so that if they do a drop in the GCS, you can then get a CT head. And again, always ask for help whenever you need it from a senior. If you're unsure about what to do with a patient, or you're unsure about what to include in the management plan, you can always escalate to a senior. And I would always recommend to do that. It's better to ask for help and then not need it than to not ask for help and then find out you need it when it could be too late. And so these are some of the things that we can do to prevent falls for the patient in the future. So a big one is physiotherapy. So again, if a patient comes into a hospital because they had a fall at home, most likely what happens is they then get physiotherapy whilst they're in hospital to make sure that they get them back to the baseline that they were before they came into hospital, before the fall itself. And because these patients are quite elderly and frail, sometimes when they do have a fall, they have a massive setback. And that's because they get very deconditioned from the fall itself. And that's why it's important to have the physiotherapy that we have on the wards that we offer in hospital, so they can get these patients back to how they were before when they had the fall. Again, medication review. So to stop unnecessary medications that patients don't necessarily need. And if a patient is on a lot of medications, so they're on polypharmacy, what can we do to prevent them being on all of these medications? Can we stop some? Can we reduce the dose of some? Can we offer an alternative drug instead of one which might be causing the patient to have a fall because of its side effects? Ensure the patient is well hydrated. So again, dehydration is one of the risk factors for a fall. Making sure that everything is within the patient's reach, which is, I think, is an important one, because again, majority of these falls are going to be in the elderly patients. And so when they're lying in bed, if things aren't around them that they need, this just essentially gives them incentive to get out of bed and go and get something that isn't within their reach that they need. And so doing this, especially if they don't utilize their core bell, then it could put them at risk for a fall. And for those of you who don't know what a core bell is, it's essentially, it's a small button that the patients can press, which notifies the ward staff that they need assistance with something. So someone can come to the room and they can help them. And sometimes what you find is patients don't use this core bell and do things on their own. And this is why they're having the falls. Again, point 6, ensure appropriate footwear is being worn. So they have their slippers on, and the patients are comfortable in walking in what they have on. So would that be the socks or the slippers? The walking aid is within reach. So when they do get out of bed, they don't have to walk on their own without any aid to get the aid in the first place, because that would just be counterintuitive. So just make sure that whatever the patients need is within reach. Making sure the space is clear. Using the side rails on the bed is also an important one, and that's to stop the patients from essentially getting out of bed and having a fall. And then point 10 is a 1-to-1. And what I mean by this is essentially in a patient who is confused. Let's say someone comes to hospital, they've been treated for a chest infection, they're otherwise GCS 15, but now the chest infection has become worse, and now they're slightly more confused than usual due to the infection. As we know, infection is one of the causes of delirium in the pinch me mnemonic that I showed you. And so now they're a bit more confused than usual. And this means that the patient is now getting out of bed and just trying to walk around without the frame, which is obviously putting the patient at risk. So what we do to prevent this is putting in a 1-to-1, which is essentially where one member of staff on the ward is going to sit with the patient and just observe them, 24/7, to make sure that when they do get out of bed, that person can intervene so they don't, and then just reduce the risk of falls. And if the patient doesn't have capacity because of the infection, we can put what's known as a DOLS in place. So this is to essentially make decisions for the patient's healthcare in their own best interests, because they're unable to due to the lack of capacity at the time. So I was going to do a case study for discussion. Now, I don't know whether I can look at the Q&A. I can ask some questions and get people to contribute in the Q&A whilst I'm doing this, or should I just go through it and ask the questions at the end? I'm not entirely sure.
But if you have a preference, we can try it.
Yeah.
You can pose the questions or the thoughts, the discussion, and then you can open up the Q&A and people can type in their answers. And again, just don't read out anyone's name. You can just read the answer.
Okay.
Fine. There's a couple in there about it being recorded, so you can ignore those and go to the next one. Okay, cool. I can't view the Q&A box here, so I think you might have to stop me being host so I can see it. Okay. We'll leave it on this slide if that makes sense. So this is just going to be a case study that we're going to quickly discuss, and it's just going to use some of the things that we've spoken about during the webinar. So if you can type in the Q&A as to what you would do or what you would ask for, etc., it would be helpful. So, and just pretend like you're the doctor working on call, essentially, and I'll pretend to be the patient. So whatever questions you ask, I can answer as the patient. So the nurse bleeps you and tells you that, doctor, we've got a gentleman on the ward. He's 85 years old and he's fallen. Can you come and review him, please? Yes. Good. Got some questions, got some answers coming through. Okay, yeah. So like I said, when the nurse calls you and tells you that the patient's had a fall, you want to utilize the conversation on the phone. So yes. So number one, you can ask, okay, you can ask for a full set of obs. That's correct. So what I would do is I would ask, okay, how is the patient at the moment? And when you ask that, the nurse says, he seems a bit more confused than usual. It's not really like him. He's been a bit, he's acting out of the ordinary for the last sort of couple of hours or so. So yeah, okay. So yes, you ask for a full set of obs. You can ask, did they hit the head as well, which is a good thing. And when you ask, did they hit the head, and she says yes or no, you always just ask whether on anticoagulation. Yes. So got some good answers coming through. So what happened during the fall? And when you ask that, you're going to establish whether it was unwitnessed or witnessed. So when you ask that, the nurse says, well, we didn't really see him have a fall. We just saw him about a couple of yards from his bed on the floor. And so we rushed over and got him back to bed. So what you want to do is ask for a full set of observations, ask for an ECG, and ask for a capillary blood glucose. Okay. And then it's always nice to tell the nurse sort of a rough timeline of when you're going to get there to see the patient. So you say, okay, I'll be there in 10 minutes time. And so at least the nurse knows when you're going to get there. Okay. So you've got a bit of brief collateral from the phone call with the nurse. You already know that this guy's acting out of the ordinary. You're probably a bit more confused than usual, but you've asked for a full set of obs, you've asked for the ECG, you've asked for a CBG, and now you're making your way over to the ward to go and see this gentleman. So when you go and see him, what are you going to do? Can you remember the categories of what we're going to do in terms of the fall? Yes. So you want to establish what happened before the fall, what happened during the fall, and what happened after the fall. Okay, so you go into this gentleman's room, he's on his bed. He looks relatively well from the bedside. And so you go and you ask these questions. And the gentleman says, oh, hi, are you one of the doctors? And you say yes. And he says, oh, how can I help? And you say, oh, well, I've come to see you. I've heard that you've had a bit of a fall. And he says, I don't think I've had a fall, doctor. And
And then he says, oh, can I have my breakfast? And then you look at the time and it's 9 p.m. and you're on call shift and you're thinking, okay, something doesn't seem right here. So you obviously can't get a collateral history from him about the fall. So what are you going to do now? Yes, so you can do the 4AT. So this gentleman is obviously confused, and now you want to do 4AT to see whether this patient is scoring for delirium or not. Okay, so you do your 4AT and he scores a 6 out of 12, which is suggestive of delirium. So what do you want to do now? Because you obviously can't ask him what happened during the fall, but you also don't know whether this is normal for the patient. Is he normally confused? Does he have an underlying cognitive impairment? Maybe this is normal for him. Yes. So what I would do if I was on call in that situation, there's two things. Number one, I will check the patient's notes to see whether this is his established baseline. Is he normally this confused? Look at his past medical history. Does he have a diagnosis of dementia? Alzheimer's. Does he have any underlying diagnosis of a cognitive impairment? If so, then this could be his normal baseline. And the next thing, number two, is to ask the nurses. Like I said, the nurses are the people who know the patients the best. They are with them most of the time during the day. So when you go and see the patient on the ward and you're unsure, always ask the nurse, how do you feel he is today? And when you go and ask, so you go and look for the notes, you can't really see any underlying cognitive impairment for this patient. You look for the ED notes and he's otherwise GCS 15. And you go and speak to the nurse and the nurse says, well, yeah, he's been a bit more confused actually than he was compared to yesterday when I was on shift. He was doing things like trying to get out of his bed and saying that he needed to go to the toilet, which isn't like him, and he doesn't really know where he is at the moment. So now you establish that this is a new confusion for this chap. You don't really know exactly what happened during the fall because, like the nurse told you on the phone, it's unwitnessed. They just found him on the floor a couple of yards from his bed. So what are you going to do now? So you've already gone to go see the patient. You've already established that this patient is probably more confused than usual. He's had a fall, but you're unsure why he's had the fall in the first place. You know, looking through his notes, that he has no underlying cognitive impairment. And you know that you can't really get a history as to what happened exactly during the fall. So now you need to do investigations. Okay. So we've already established his 4AT, but now once we've done the 4AT, what are we going to do when we examine the patient? Yes. So we're going to do an A2 examination. So we start with A, airways. The patient's talking back to us. He's absolutely fine. So his airways are patent. He's maintaining his own airway. B, for breathing, we auscultate his chest. Chest is absolutely clear. There's nothing in the chest that we can see on examination, which is abnormal. His observations that the nurse took are absolutely fine. His respiratory rate is fine. He's saturating or absolutely fine, 99% on room air. We listen to his heart. Heart sound is regular. There's no murmurs that you can hear on auscultation of the heart itself. His blood pressure, as we can see on screen, is 115/89, and his heart rate is 67. And when you look at the trend of his blood pressure, is trending on the low side, really. So his blood pressure has been a bit on the low side, and his heart rate as well has been a bit sort of fluctuating between 60 to 70. And one thing I forgot to mention is a past medical history for this patient, which is seen on screen. So he's type 2 diabetic. He's had a total knee replacement 5 years ago, and he's got a history of heart failure. And his medications that he's on is on the screen at the moment. So we've done C. There's nothing abnormal from C. We do go to D. So we check his GCS. His GCS at the time is, I would say, 14. And his capillary blood glucose level that you kindly asked the nurse to take when you were on the phone to her before you went to the ward is absolutely fine at 6.7. Okay. You go to E, which is when we want to do a head-to-toe examination. So no obvious head injury on inspection of the patient themselves. There's no laceration, there's no sort of bruising, there's nothing you can see on the head, there's no neck stiffness, there's no spinal or cervical stiffness on palpation when examining the patient. When you go down, there's full range of motion of the arms, there's no weakness, there's good tone, sensation is intact. And then you go down and then you palpate the abdomen, and you actually see that there is some tenderness on the suprapubic region. Okay. And it's very, very painful for the patient. Well, not painful, but you can see that the patient's in distress when you're putting pressure on the suprapubic area. So that's one thing that you picked up from your examination for the patient. So you're thinking in your mind, okay, he's got suprapubic tenderness. So then you proceed with the examination. He's got good power and tone in his legs, no weakness whatsoever, reflexes are intact, and there's no obvious injury at all anywhere. So you go and look back through the patient's notes and you see that this patient was admitted with a urinary tract infection. And he is currently on a course of antibiotics at the moment, which is due to finish in 3 days' time. Okay. So what's the things that you're thinking at the moment, given everything? Okay, so yeah, like furosemide, check bloods, imaging, infection. Yeah. So urinary tract infection. Yeah. So let's break this down. So this is an 85-year-old gentleman. He came in with a urinary tract infection. Okay. He was GCS 15 at the time when he came in. He's now had a fall on the ward, which is why you're going to review this chap. He has a past medical history of type 2 diabetes, but we know, checking his capillary blood glucose level, that it was within normal range, so there was no hypo episode. He's had a total knee replacement 5 years ago, so potentially he's obviously got some osteoarthritic changes, which could be hindering his mobility to begin with in the first place. He has a background of heart failure as well. The medication he takes is bisoprolol, which is 2.5 milligrams, furosemide 40, a statin. He's taking paracetamol, and then he's taking metformin for his diabetes. Now you see that the gentleman is more confused than usual, which is not normal for him. After looking through the notes and also confirming with the nurse after taking collateral, you don't really know why he fell because no one saw. And now at the moment, his OBS, his blood pressure is 115, his heart rate 67. He, on a physical examination, the only thing that you can see is a suprapubic tenderness. And so what do you think you're going to do, include in your plan? So review meds like furosemide, yes. So medications, like I said, the things that are going to go in our plan regardless are lying and standard blood pressure, an ECG, and medications review. Okay. Yes. So urinalysis. So we know this chap came in with a urinary tract infection. Now, it's always good if someone comes here with a urinary tract infection suspected, we treat it. However, it's always good to send off an MSU. So we send it to the lab so it can be cultured, and then we can sort of amend the antibiotics according to the sensitivities. But this chap is already on antibiotics, okay? So he's already been treated for his active urinary tract infection. But we can include in the plan to send off an MSU, yeah, to determine the organism which is causing the urinary tract infection. We can do bloods just to make sure that his blood, his inflammatory markers are improving in response to antibiotics that he's on at the moment. Okay. Yes, so this is a very good question. When was the last time he passed urine? Okay. So always go back to a physical examination. This chap came with a urinary tract infection, and now he's become acutely confused and he's got suprapubic tenderness. And if you remember, if you go back to delirium, pinch me mnemonic, it's P, which is pain, I, which is infection, C, constipation, hydration, and alongside constipation, I said urinary retention. Okay, now this chap is being treated for an active urinary tract infection. and usually in people who do have a urinary tract infection, puts them at increased risk of urinary retention. And this chap has got severe suprapubic tenderness. So what do you think? How do you think we can investigate this further? So we said ultrasound, we said KUB, neurologic examination to assess whether the confusion is due to infection alone or something else too. We can do, but on our neurological examination, it was absolutely normal. There's nothing abnormal in the neurology whatsoever. So we got another KUB. Now, one very, very simple, quick investigation that we can do is a bladder scan. Okay. And it's very simple. You can either do it yourself or you can get one of the nurses to do it. Okay. And all it is it's sort of like an ultrasound monitor on wheels. You push it into the room, you put a bit of gel on the suprapubic area, you get the probe, you put it on, and it will automatically record how many milliliters of urine are within the bladder. And so you ask the nurse to do a bladder scan. And what you find is this chap has about 900 milliliters of urine within his bladder. Okay. And if you remember, the nurse was saying that he kept on getting out of bed to try and go to the toilet. So yes. So what we want to do in this circumstance is we want to catheterize this patient. Okay. And this is going to get rid of all of this urine which is present within his bladder. So what we do is we catheterize the patient, and now the urine is coming out, and the patient is feeling somewhat of a symptomatic relief in terms of the pain with the abdomen. So that's going on in the background. Now, what else can we do in the plan for this patient? Yeah, that's also a good point. You can also ask the patient when they last had a bowel movement, and if they can't answer, you can ask the nurses or look through the notes. And if they've been constipated for quite a while, this can also lead to urinary retention as well. So that's why it's important to ensure that the patient's always opening their bowels as well. Yeah, so we want to continue with antibiotics. So there's a couple of things. So we're going to do an ECG. We're going to do a lying and standing blood pressure for this chap. We are going to review his medications, which we'll speak about. We're going to get a bladder scan, which we've already done, which showed 900 milliliters in the bladder. And now we're getting him catheterized, and that's in, and that's working correctly. We're going to continue with the antibiotics. We can also check do some bloods to make sure that his inflammatory markers are going down in response to the antibiotics. We're going to send off an MSU as well. Yeah, exactly. Yeah, continue antibiotics and wait for the MSU. Yeah, so obviously with him being an 85-year-old gentleman and he's in urinary retention, now it could be due to the urinary tract infection. However, it's also possible that he's got a enlarged prostate. Now, what we can do is we can get an ultrasound KUB, which would show as the enlarged prostate. However, at the moment, it's more likely that the urinary retention is secondary to the urinary tract infection itself. Yeah. Continue antibiotics some way with MSU. Yeah, so that's all correct. So we're going to come to medications review. So what do you think we can do in terms of the medications to based on his observations and the trend of his blood pressure, which I spoke about, because it's been on the low side? So what suggestions would you give in terms of his medications? What do you think that we could change or alter? Yeah, so furosemide, yeah. So the chap has a past medical history of heart failure. Now, his blood pressure is 115/89. However, we've seen that over the past sort of 5 days or so since he's been in hospital, it's been trending on the low side. So his systolic has been about 100 to 110, and today it's 115/89. Okay, and his heart rate is 67. Now, I can tell you that he has systolic heart failure as well. So going through the medications, which I said, which can promote falls, included in those was diuretics and beta blockers. Okay. Now, in his case, his blood pressure has been on the low side and his heart rate is sort of on the low side as well. So bisoprolol, we can potentially decrease to 1.25 milligrams. Now, because he does have a background of heart failure, it is important that we don't completely take him off the beta blocker completely. And does anyone know why that is? Yeah, I mean, the beta blocker is used in his systolic cardiac failure, essentially, and should be maintained whenever it can. I mean, we shouldn't stop it completely, but because his blood pressure has been trending on the low side, it would be a good idea to reduce it, and then we can monitor his blood pressure to see what it's like in the future. Now, in terms of his furosemide, with it being a diuretic, it can cause hypotension, and it can cause low potassium, low sodium, and this can result in lightheadedness and promote a fall as well. And he does have a past medical history of heart failure. Now, if the patient isn't symptomatic and he doesn't have signs of congestion, if he doesn't have signs of heart failure at the moment, so for example, he has no pedal edema, does he need to be on the 40 milligrams? Can we reduce it to 20 milligrams? So that's also something we can think about as well. So reducing the bisoprolol to 1.25, and he's even reducing the furosemide to 20 milligrams as well. Okay. Yeah, good. Excellent. So hopefully that was useful for you and got your brain thinking a bit. But when you are working on call, just make sure that you just take a step back and you take a breath and just approach the patient in a systematic way, just like anything else when you are working on call as a doctor. So in this circumstance, number one, utilize a phone call with the nurse when you call back after you get bleeped from them and they say that a patient's had a fall. So get a bit of background history of the fall itself, of the patient, ask for the necessary investigations that you can do. So observations, ECG, capillary blood glucose. When you get to go and see the patient, always get a before the fall, during the fall, after the fall. Okay. Look through the patient's notes, get to know their journey as to why they've come to hospital in the first place. Okay. And then once you've done that, you can then go and assess the patient, do an AT examination. And then based off of all of this, you can then make your plan and cater that towards your examination findings. So thank you for your attention and tuning in. So if you have any questions, you can put it in the Q&A and I will try to answer.
Great, thank you, Joshua. For those of you who joined a little after the beginning, as Dr. Soggi just requested, if you guys could put any questions you have in the Q&A, he'll be able to answer them without revealing any of your personal data, since again, we do have this recorded and we will be putting it on YouTube. We won't be announcing the names or having you guys ask the questions, again, to protect your personal data. So feel free to put them in the Q&A function and he'll go ahead and answer them for you.
Yeah. So why beta blockers can't be completely stopped in heart failure, especially in this case. So as you know, beta blockers are one of the cornerstones in the treatment of heart failure itself. And that's because of the survival benefit in systolic cardiac failure. So that's why we're not going to completely stop it in this case, because it's actually beneficial for the patient to be on the beta blocker than completely stopping it altogether. But we will reduce the diuretic because if the patient has no signs of congestion on examination, for example, peripheral edema, etc., of heart failure, then we can reduce the dose of the diuretic. Yeah, the same process of the assessment, absolutely. So the same process will be for every single patient that you come across, irrespective of whether they've got a DNAR or not, and irrespective of whether they've got a DOLS or not. Now, with the DOLS, that usually is telling you that the patient doesn't have the capacity to consent for their own healthcare at that time. So that's why the DOLS is in place, so we can make decisions on behalf of the best interests of the patient. Now, in those circumstances, they're probably unlikely to give you a history of why the fall happened in the first place, in which case, that's why we rely on a collateral history. So getting it from the nurses, if we can, on the wards, getting it from the HCA staff on the wards, and even if the family is present, we can get it from the family if they were there during the fall as well. So how about bleeding after the fall? So it really depends, how severe the bleeding is and where the bleeding is from, essentially. Now, if it's a minor cut and the bleeding, then usually you can apply dressing. The nurses are very good at it, and this will help reduce the bleeding as well as patch the injury itself. But if it's more extensive bleeding, then that's when, if you're not confident doing it yourself, then you would have to contact someone else who would come and suture the wound itself if it's a nasty laceration and they are bleeding. So when writing a discharge summary, it's not necessary to include everything in terms of the fall. So what happened before the fall, what happened during the fall, what happened after the fall. But it's important to note that the patient did have a fall whilst they were in hospital, and the resultant outcome of the fall. So if there was any imaging which showed a fracture, etc. So it's just the main points that you include in the discharge summary, because it's impossible to include everything. So witness refusal of blood and blood products. So that's obviously an ethical scenario. So and that's down to the patient's own religious beliefs. So if you do come across a situation like that, then, and even though the patient needs the blood products, but because of religious beliefs, they don't want them, then you do have to go by the patient's wishes as long as they have capacity. But I'm not an expert in that sector, because there is also a lot of other things which could contribute to the actual decision as well, in terms of who the blood products are for, whether they have capacity at the time, or making a decision on behalf of themselves or it's someone else. So that's when you involve seniors and get their own opinion as well based on the matter. Any other questions?
We did have another one. Someone asked, what if the patient has congestive heart failure?
Oh yeah.
And the systolic BP is 90. What are we doing about the furosemide? I didn't say that right, but you know.
Yeah, so if the patient has congestive heart failure and the heart is fluid overloaded and they do have a low blood pressure, then what are you going to do? So this is obviously a tricky situation in terms of the patient has congestive heart failure, they're symptomatic, maybe they've got a bit of fluid on the lungs, but they're also hypertensive at the time as well. So it's a tricky situation where you have to monitor with diuretics to extract the volume, but also you don't want to extract too much volume to lower the blood pressure significantly. So in scenarios like this, where it's very hard to make the decision, I would always suggest consulting with a senior on the management, just in case you're doing the right thing. And like I said, working as a doctor for the first time, there's three main things which is going to make you a competent F1, which is time management, prioritizing your task, and asking for help whenever you need it. And a situation like this, where you come across a patient where they have low blood pressure, but they're also in a symptomatic fluid overload, then you should be asking for help.
Thank you so much, Dr. Soggi, for all of your time today. That was incredibly interesting, and it seemed like everyone really learned quite a bit. There were good questions and good participation in the scenario that you brought up. So that was fantastic. We really appreciate it.
No worries. Hopefully it's helpful for everyone who tuned in, and maybe even if they remember a few things of what I taught and incorporate it into when they see falls on the wards, maybe it will help them and make things a lot easier.
Yeah, hopefully you passing on this knowledge just helps save some more people from complications while they're in the ward. So
yeah.
So just to wrap up, for everyone participating, we want to do a quick plug for one of our sponsors, Lecturial. This is an application that you guys can get a discounted access for. You can access a variety of high-yield medical video lectures. You can take a closer look at the human body with scientifically accurate 3D anatomy models. You can test your knowledge and assess your learning progress by answering interactive quiz questions, prepare for exams using the most advanced question bank available, and even better, all of Lecturial's exam-style clinical case questions include text and video answer explanations. So it's a really great study tool, and SME students get a 20% discount for participating in this symposium. So here is the QR code for anyone interested in getting the certificate of attendance, and also the Lecturial discount code. I'll leave this up for a second as we end the recording, and you guys can take a moment with that.